Hello guys. I am Docsaab and today we are tackling a topic that is as common as it is complex. Erectile dysfunction or ED. Often dismissed as just aging, ED is a multifaceted issue signaling a potential cardiovascular, metabolic or psychological risk. We will explore its causes, diagnosis and evidence-based fixes drawing from the latest guidelines. By the end, you will feel equipped to manage this in your practice. Let's dive in. Erectile dysfunction, also known as impotence, is defined as the persistent or recurring inability to achieve or maintain a penile erection with sufficient rigidity and duration for satisfactory sexual activity. It is the most common sexual problem in males and can cause psychological distress due to its impact on self image and sexual relationships. The term erectile dysfunction does not encompass other erection related disorders such as priapism. It is not merely a side effect of aging, it is a red flag for underlying health problems impacting psychosocial well being and quality of life for patients and partners alike. Prevalence is staggering. Globally, it affects 322 million men by 2025, with rates climbing from 4% in 40-year-olds to 50% in 70-year-olds. In India, urbanization, poor diets, limited screening contribute to 20 to 30% prevalence among men over 40. Cultural sensitivity is key. Stigma often leads to underreporting, so always involve partners and screen gently. ED's etiology is a multifactorial, blending organic, vascular, systematic, and psychogenic elements. Remember the mnemonic VS and PP for quick recall. That means vascular, systematic, neurologic, penile, and psychiatric. In general, ED is divided into two broad categories, organic and psychogenic. Although most ED was once attributed to psychological factors, pure psychogenic ED is in fact uncommon. However, many men with organic etiologies may also have an associated psychogenic component. Organic causes dominant, think vascular issues like atherosclerosis, peripheral vascular disease, myocardial infarction, or arterial hypertension, vascular injuries from radiation therapy or prostate cancer treatments, plus trauma from activities like long distance cycling play a role. Systemic diseases such as diabetes mellitus, scleroderma, renal failure, liver cirrhosis, idiopathic hemochromatosis, and cancer or its treatments, dyslipidemia and hypertension further fuel this. Neurological causes include epilepsy, stroke, multiple sclerosis, Guillain-Barré syndrome, Alzheimer's disease, and trauma. Respiratory issues like chronic obstructive pulmonary disease or sleep apnea add to the mix. Endocrine conditions, hyperthyroidism, hypothyroidism, and hypogonadism often coexist with diabetes. Penile conditions like Peyronie's disease or epispadias. Psychiatrist factors such as depression, widower syndrome, performance anxiety, or PTSD, and nutritional states like malnutrition or zinc deficiency. Hematologic diseases including sickle cell anemia and leukemias round out the picture. Surgical procedures, brain, spinal cord operations, lymph node dissection, bypasses, or prostatectomies can damage nerves. And medications like antihypertensives, antidepressants, antipsychotics, anti-ulcer agents like cimetidine, 5-alpha reductase inhibitors such as finasteride or dutasteride, cholesterol-lowering agents, and methadone. Erectile dysfunction is a multifactorial condition rooted in the disruption of the physiological process of penile erection, which involves coordinated vascular, neural, hormonal, and psychological elements. The core mechanism hinges on the nitric oxide cyclic guanosine monophosphate pathway, where nitric oxide from endothelial cells and nerves activates soluble guanylate cyclase to produce CGMP, leading to smooth muscle relaxation in the corpora cavernosa, vasodilation, and blood inflow for erection. Phosphodiesterase type 5 terminates this by degrading cyclic GMP. In ED, this pathway is impaired, often due to endothelial dysfunction, oxidative stress, or structural changes. Vasculogenic pathophysiology, the most prevalent form up to 80%, driven by atherosclerosis, hypertension, and diabetes, which reduce nitric oxide bioavailability via eNOS uncoupling and increase reactive oxygen species. Vascular aging exacerbates this, with age endothelial cells showing reduced L-arginine conversion to nitric oxide and impaired SGC activation, leading to cyclic GMP deficiency and fibrosis in penile tissues. In diabetes mellitus, hyperglycemia accelerates atherosclerosis, and autonomic neuropathy, with pathways involving advanced glycation end products and inflammation disrupting ANO signaling. Neurogenic pathophysiology involves damage to pudendal nerves or spinal pathways, common in multiple sclerosis, Parkinson's, or post-prostatectomy states. This impairs nitric oxide release from nerves, reducing cyclic GMP production. Diabetic neuropathy adds peripheral nerve degeneration, further isolating the erectile response. Hormonal and systemic factors. Hypogonadism affects libido and vascular health, while metabolic syndrome promotes insulin resistance and inflammation. MicroRNAs like MIR143 and MIR145 modulate smooth muscle proliferation and fibrosis, contributing to veno-occlusive dysfunction. Oxidative stress and inflammation. Reactive oxygen species from smoking, obesity, or aging inactivates nitric oxide and promote apoptosis in endothelial cells, creating a vicious cycle. This is particularly relevant in Indian population with high metabolic syndrome rates, where oxidative stress links ED to cardiovascular risk. Psychogenic and mixed mechanisms. Psychological factors like anxiety alter central nitric oxide release, while mixed cases involve vascular and neuronal overlap. In 2026 updates, emerging research highlights epigenetic changes and gut microbiome influences on nitric oxide pathways. Diagnosis demands a systematic, patient-centered strategy per AUA 2018 guidelines and EAU 2025. The goal is to assess severity, risk factors, and underlying etiology, starting with history and physical exam. Start with history. Use the International Index of Erectile Dysfunction or Sexual Health Inventory for men to quantify severity in mild, moderate, and severe. Key elements include onset, means gradual versus sudden, duration, associated symptoms like dysuria or fatigue, medication review, and psychosocial factors. In India, cultural sensitivity is crucial. Stigma may underreport, so involve partners if possible. Physical examination to evaluate cardiovascular system for peripheral pulses, BMI, neurological for perineal sensation, and genital for testicular atrophy, penile plaques. Check for hypogonadism signs like gynecomastia or CVD indicators like carotid roots. Laboratory panel include fasting glucose, HbA1c, lipid profile, renal function, and morning total free testosterone. For diabetes mellitus or CVD high risk patients, add HbA1c and lipids. Advanced tests include nocturnal penile tumescence to rule out psychogenic ED, normal if more than 3 erections per night, penile Doppler ultrasound for arterial inflow, such as peak systolic velocity less than 25 cm per second suggest venous leak, biothesiometry for neuropathy. In 2026, microRNA profiling is emerging for molecular diagnosis. Comorbidity screening, given it is linked to CVD, perform ECG, stress test, or Framingham risk score. In India, screen for diabetes mellitus and metabolic syndrome as ED correlates with the hyperglycemia and CVD mortality. Treatment is personalized, starting with lifestyle modification and addressing comorbidities per AUA 2018 and EAU 2025. The stepwise algorithm prioritizes non-invasive option with 70 to 80% efficacy for first-line therapies. Lifestyle and non-pharmacological interventions. Dietary intervention, adherence to a Mediterranean diet rich in fruits, vegetables, whole grains, and monosaturated fats lowers ED risk and improves function in metabolic syndrome by enhancing nitric oxide bioavailability and reducing systemic inflammation. Physical activity and weight management, obesity, sedentary behavior are primary drivers of metabolic syndrome and ED. So at least 150 minutes of aerobic exercise weekly improves lipid profiles and glucose metabolism, directly countering vasculogenic ED. Substance cessation, smoking is a potent vasoconstrictor causing endothelial damage, mandatory to prevent further degradation. Similarly, reducing excessive alcohol intake mitigates neurological and hormonal suppressions. First line pharmacological interventions, PDE5 inhibitors, the gold standard. They work by inhibiting the enzyme responsible for degrading cyclic GMP, thereby prolonging smooth muscle relaxation and blood inflow. Sildenafil, the first in class agent, requires administration on an empty stomach for optimal absorption. Usual dose 25 to 100 mg, starting at 50 mg, taken 30 to 60 minutes before sexual activity. maximum dose 100 mg. Tadalafil, notable for its long half-life up to 36 hours, allowing for daily dosing 2.5 to 5 mg, which decouples medication timing from sexual activity. Usual dose 10 mg taken as needed or 5 mg daily. Vardenafil, similar to sildenafil with slightly longer duration. Usual dose 10 mg taken 60 minutes before sexual activity. Avanafil, a newer agent with rapid onset of action, approximately 15 minutes, and high selectivity, potentially reducing side effects. Usual dose 50 to 100 mg, taken 15 to 60 minutes before sexual activity. Clinical consideration. Common side effects include headache, flushing, dyspepsia, and nasal congestion. Physician must emphasize that this medication requires sexual stimulation to be effective. They are not initiator of arousal but enhancers of the physiological response. Safety and contraindications. The most critical contraindication is the concomitant use of organic nitrates such as nitroglycerin, which can cause catastrophic hypotension. Patients must also be screened for cardiovascular stability before initiation. Other contraindications include severe hepatic or renal impairment and concurrent use of strong CYP3A4 inhibitors such as ketoconazole, ritonavir for avanafil. Now, second line pharmacological therapies, alprostadil, prostaglandin E1 for patients who do not respond to oral PDE5 inhibitors or have contraindication, bypassing the nitric oxide pathway to induce smooth muscle relaxation directly. Intracavernosal injection. This involves the direct injection of alprostadil into the corpora cavernosa. It is highly effective, 80% success rate, but requires patient training on injection technique. The primary risks include penile pain and rarely a priapism or corporal fibrosis. Usual dose 1.25 to 12.5 microgram, starting at 2.5 microgram, titrated as needed. Transurethral system, a less invasive delivery method where a small medicated pellet is inserted into the urethra. While easier to administer than injection, it is generally has lower efficacy and can cause urethral burning. Usual dose 125 microgram inserted into the urethra 5 to 10 minutes before sexual activity. Clinical utility. These therapies are particularly useful for patients with severe neurogenic ED, example post-prostatectomy, where the neural pathways required for PDE5 inhibitor efficacy are damaged. View 1 shows direct injection of prostaglandin E1 alprostadil into the corpora cavernosa. View 2 for intraurethral alprostadil therapy. A small pellet of alprostadil is inserted via an applicator into the urethra where it is dissolved by residual urine. Let's talk about hormonal management. Testosterone replacement therapy, TRT for ED, frequently comorbid with hypogonadism. TRT is indicated when a patient presents with consistent symptoms of androgen deficiency and confirm low serum testosterone levels, typically less than 300 nanogram per deciliter. Diagnosis and initiation. Diagnosis requires at least two separate morning blood tests. Clinicians should also measure PSA, hematocrit, and prolactin before starting therapy. Formulations. Options include transdermal gels, intramuscular injections, and subcutaneous pellets. Gels provide stable physiological levels, while injection may cause peak and valley symptomatic fluctuations. Transdermal gels 5 to 10 gram applied daily to clean dry skin, such as androgel 5%. Injections 100 to 200 mg every 1 to 2 weeks, such as testosterone enanthate. Pellets implanted subcutaneously every 3 to 6 months. Monitoring and risk. Mandatory monitoring of PSA and hematocrit is required to manage the risk of erythrocytosis and monitor prostate health. While TRT improves libido, it may need to be combined with PDE5 inhibitors to fully resolve erectile dysfunction in men with mixed etiologies. These images showing different formulations of testosterone replacement therapy. Mechanical and surgical solutions provide reliable long-term results for refractory organic ED. Vacuum erection devices, a non-invasive cylinder that uses a manual or battery-operated pump to create a vacuum, drawing blood into the penis. A constriction ring is then placed at the base of to maintain the erection. It is a safe, cost-effective option, though some patients find it cumbersome. Penile prosthesis implants, malleable, semi-rigid, consist of two firm but bendable rods, simpler to implant and operate but results in a permanent state of semi-erection. Implantable three-piece is the most advanced option, consisting of cylinders a reservoir and pump in the scrotum provides the most natural appearance and function with high rates of patient and partner satisfaction. Surgical consideration: implantation is irreversible as the procedure destroys the natural erection tissue. It is reserved for patients who have failed all other conservative measures. These devices are plastic cylinders that are placed over the penis. Air is pumped out, causing a partial vacuum. Releasing the vacuum after a few minutes and then reapplying the vacuum sometimes gives a better result. After an erection is obtained, a constricting band is placed at the base of the penis. Let's talk about emerging and investigational therapies. The field of restorative urology aims to move beyond symptom management toward curing the underlying tissue damage. Low intensity extracorporeal shockwave therapy. This non invasive treatment uses acoustic waves to trigger microtrauma, which stimulates angiogenesis and recruits stem cells to the penile tissue. It is currently recommended by some guidelines for mild to moderate vasculogenic ED. Regenerative medicine research into stem cell therapy and platelet rich plasma injection is ongoing. These therapies aims to repair damaged endothelium and nerves. While promising, they remain largely experimental, are not yet recommended for routine clinical use outside of trials. ED is rarely purely physical. The performance anxiety resulting from organic ED can create a self sustaining cycle of failure. Psychosocial assessment: clinicians should screen for depression, anxiety, and relationship discord. In many cases, it is the first sign of significant psychological distress. Therapeutic interventions: cognitive behavioral therapy and sex therapy can help patients reframe their expectation and reduce anxiety. Partner involvement, including the partner in the treatment plan, significantly improves adherence and outcomes. Education helps the partner understand that ED is a medical condition rather than a reflection of their attractiveness or the patient's interest. In summary, ED demands a holistic lens. Treat the man, not just the symptom. From lifestyle to advanced therapies, we can restore function and confidence. Thank you guys. For more, like, share, and subscribe to the Docsaab's Diary.